just about a year ago, I started researching cardio-oncology in earnest, in part because I've had my own health issues with heart stuff, and in part because I was hearing more and more from other survivors that they were also suffering with cardiac issues and didn't really know where to go and who to talk to. And too many of them were a little surprised by what was happening to them, all of which is not great. And I started researching and calling people, and Dr. Okwuosa was the first person to call me back by herself without a secretary or an assistant. She called right away and we had a great talk, and I cannot tell you how much it means to have a clinician like you do that for us. It's wonderful, it's amazing, and it's very rewarding. It's one of the things that gives us hope and optimism to know that there are people like you out there who care enough to make the personal contact and teach us what you know about cardio-oncology and help us to get the kind of care that we need. So that would be the best introduction I can give. And your credentials and your experience and your work and your research is all terrific. But the fact that you picked up that phone and called was such a gift to me. So I want to thank you for that. So I'm going to let you take it from here, and I'm going to go off camera, and Gail and Kathy will jump in as hosts. Thanks, everybody.
Erin, thank you so much for having me here today. And I want to thank everyone who's here, who's joining this. Like Erin said, I called her right away. And what's the reason for that? Because heart disease and cancer is what I do for a living. It's what I do. It's how I take care of my patients who have cancer. Basically, almost everyone in my clinic is a cancer patient, even though I'm trained as a cardiologist. And so I take care of the cardiovascular disease associated with cancer therapy while they're going through cancer treatment or afterwards. And this topic is near and dear to my heart. And, Erin had wanted me to talk initially off the cuff, but I decided I wanted to use a PowerPoint presentation. I wanted to make this a PowerPoint presentation. And the main reason is because I felt that there's a lot of data out there and a lot of information out there that I wanted to share, that I felt going through the visuals, I think would help a lot more than me speaking. They say pictures speak 1,000 words. And so, like I said, this is a topic that's near and dear to my heart, and I'm very passionate about it because one of the things that really bothers me is people go through cancer treatment and cancer therapy, and then all of a sudden they drop dead from heart disease. And I think that's extremely sad because a lot of it is preventable. So without further ado, I'm going to go ahead and share my screen. Can everyone see my screen now? Yes, no, maybe? Yes. Okay, great. Yes. All right, I am going to put it in slide mode. Okay, great. So like I said, again, my name is Dr. Okwuosa. I'm a cardiologist at Rush University Medical Center. And we do have a number of initiatives in cardio-oncology at Rush that I run or that I founded. And I also sit on the American Heart Association Cardio-Oncology Committee, where I am the chair over there. So it's again, a topic that's near and dear to my heart. So we'll start off with epidemiology. So when we talk about death rates for cancer and death rates associated with cancer and also associated with heart disease, you can see here that heart disease used to be the #1 killer, still is the #1 killer, but by far the #1 killer of people in the United States. And cancer was a pretty far second initially. Prior to the 1950s, when all this became such an issue or a topic, infectious disease was the #1 killer. But with the advent of antibiotics in the first half of the 20th century, that became less of an issue. And then cancer and heart disease took over. Cancer, you can see how cancer is kind of catching up to heart disease as time is going on. And part of the reason is because we've made a lot of progress with respect to managing heart disease, right? So we know now, based on the Framingham risk score, we know now the typical risk factors that are associated with heart disease. And then at the same time, we also have better remedies for heart disease, the medications that we use, the interventions for heart disease, including stenting and bypass surgery and the rest of them. And now there's more recognition of cancer, right? So cancer became a thing because now because of treatments, people would actually come to their physicians if they have cancer and be diagnosed. So we're diagnosing cancer more and also managing it more. And this is the reason why cancer is catching up with heart disease and of course, let's not forget the fact that the population is aging. And as people get older, the risk of cancer increases. So for that reason, cancer is catching up with heart disease as a number 2 cause of mortality or cause of death in the United States. And it's actually projected, and you can see how the graph continues to go, and it's actually projected that by 2030, cancer would have caught up with heart disease as the number 1 cause of death in the United States, and cancer may actually surpass heart disease as the number 1 cause of death in the United States. Right, as of 2019, we had about 17 million cancer survivors, and that number is, and this is 5% of the population. This is a huge number. It's like 1 out of 20 people are cancer survivors. And we're talking about cancer patients, but survivors particularly. And it's projected that by 2030, we would have about 22 million cancer survivors, which is like a 1/3 increase, which is a huge number. And that by 2040, we'll have about 26 million. And part of the reason why we have a lot of survivors is because, as you all know, cancer patients are living longer because of chemotherapy, radiation therapy. And also more recently, we have targeted therapies and immunotherapies, which are definitely making a huge difference and a huge dent in death according to cancer, and increasing the number of survivors that we have as a result of cancer. And so, but the good news also that these therapies, because they're increasing the amount of survivorship, they're also helping reduce the death rates according to cancer. But you can see now here that as the cancer mortality is decreasing, we're having increasing deaths from heart disease, right? So cancer mortality is decreasing, but look at all these: breast cancer, melanoma, prostate, endometrial, all the other cancers. The risk of death from heart disease is actually increasing in the process. And so this is not something to be taken lightly and something that we need to think about very much. So in this data, we're looking at survivors of childhood cancer. These are actually mostly lymphoma patients. These are the siblings in the orange or gold line, and then the survivors in the red line on this graph. And you can see the new malignancy, which I think most of you are aware, the new malignancy is one of the major causes of problems amongst cancer survivors. So new malignancy could be new cancer, or it could be recurrent cancer from the cancer that they had before. Is a major cause of morbidity in this population. And then when we look at other organ systems, so hearing problems are higher in the cancer survivors compared with their siblings, risk of kidney problems, risk of lung problems, risk of eye issues, higher in the cancer survivors compared with their siblings. But then look at heart disease. The risk of heart disease is actually pretty high, almost approaching the risk of new cancer problems that we have in this population. And so heart disease, compared to all the other organ systems, by far exceeds problems that we have with the other organ systems. And in this graph, when we look at what we call reducing cardiac reserve, in other words, as you're going down on this graph, we have increasing risk of heart failure and increasing risk of heart problems with time. As people get older, it's not surprising, and we know this, as people get older, no matter how healthy you are, as you get older, you have a decline in your cardiac function. So your cardiac function starts to go down. Those that have cardiac risk factors like hypertension, cholesterol, diabetes, all those family history of heart disease, those people have a steeper decline, more of a decline as they get older or as they age. But look at the cancer survivor, even more so than people who have cardiac risk factors. And so we usually say that people who have cancer, who have been treated for cancer, are at higher risk for having problems with heart disease compared to people who have cardiac risk factors. And so we can think about cancer and cancer treatment as risk factors for heart disease by themselves. So when we think about heart disease amongst cancer survivors, this is what we see. Higher risk amongst, when we're thinking about kids with cancer, 84% of kids with cancer will survive up to more than 5 years, which is a good thing. But then there is a 5-fold and 6-fold higher risk of heart disease compared with their siblings. And this is what we're seeing. Congestive heart failure is higher amongst the survivors compared with their siblings. MI, myocardial infarction or heart attack is higher amongst the survivors compared to their siblings. The same thing with valvular heart disease or disease of the heart valve and the disease of the pericardium, which is the sac that the heart sits in. All of these risks are higher amongst the cancer survivors compared to their siblings. And if you're thinking about Hodgkin's lymphoma, that risk of cardiac death is 30-fold higher risk of cardiac death compared to siblings, and 41-fold or 41 times higher risk of cardiac death, heart attack compared with their siblings. So again, this is a major issue. And when we think about risk factors for heart disease and cancer, there's a whole lot of them, right? Age, sex, in other words, whether you're male or female, genetics, tobacco use, diabetes, obesity, a whole bunch of things, inflammation in the environment, hypertension, high cholesterol, a whole lot of things combine to increase the risk of heart disease and cancer. And the general idea is that when you have all these risk factors, you increase the risk of developing cancer and you increase the risk of developing heart disease. But then when you develop cancer and then you receive all these treatments for cancer, including the chemotherapy, the targeted therapy, the surgery, the radiation therapy, and then on top of that, you already have all these risk factors that predispose you to heart disease, you can imagine it's kind of a double whammy. You combine both, and then you increase the long-term risk of heart problems associated with cancer and cancer treatment. And more recently, we're finding some links between cancer and heart disease. There's this thing called CHIP, which is a molecule that's now being discovered in the blood that is supposed to increase the risk of heart disease and cancer at the same time. Usually CHIP is increased when we have what we call non-ambient, what we call a mutagenic event. In other words, when there's a problem with the environment, whether it's coming from diet, from ambient radiation in the environment, from just pollution in the environment, all of these things that we talked about before, they cause some sort of mutation that makes that person develop this CHIP, which is a molecule that we find that independent of heart disease and cancer, once somebody has CHIP, the risk of developing cancer, particularly leukemia, is higher as they get older. And then the risk of developing heart disease is also higher as they get older. And this is what we have: risk of acute leukemia, risk of myocardial infarction or heart attack, risk of pulmonary embolus or clot in the lung, risk of stroke is higher amongst those that have this CHIP. And then in this particularly elegant study that was done performed amongst breast cancer patients, this is going to be a busy slide, but I'm just going to quickly explain. They actually found that if you take some mice that have breast cancer, so these are the breast cancer mouse, what we call breast cancer mouse models. If you take this breast cancer mice and you induce heart attacks in these breast cancer mice, then those mice and they compare it to breast cancer mice that got what we call a sham heart attack. In other words, they pretended like they were inducing heart attacks in those control mice, but didn't really induce heart attacks. Those mice, the ones that actually had true heart attacks, were at higher risk for developing metastases related to their breast cancer, and also higher risk of developing more tumor volume related to their breast cancer, compared to the mice who had pretend heart attacks, who did not have a real heart attack. And when they looked at the Women's Health Initiative study, I'm sure a lot of you already know about this particular Women's Health Initiative study from the early 2000s. But anyway, when they looked at this same sort of thing in Women's Health Initiative study, they found that women who had baseline breast cancer women who had baseline breast cancer who had heart attacks were at higher risk for having recurrence of their breast cancer, and also higher risk of having death related to breast cancer. So again, this is something that is concerning and major. So when we think about heart disease and heart attack and related to cancer therapy, these are the sorts of things that we see. Anthracyclines, which a good number of lymphoma patients do receive, increase the risk of heart attacks. Other drugs like tyrosine kinase inhibitors, proteasome inhibitors, alkylating agents increase the risk of heart attacks, higher risk of developing heart failure, higher risk of developing myocarditis or inflammation of the heart muscle, like we see with COVID, but also other agents cause these that are associated with cancer. higher risk of developing heart rhythm problems, higher risk of developing heart rhythm problems that have to do with the conduction system or the electrical system of the heart, higher risk of developing high blood pressure and poor circulation as a result of cancer therapy. So there's a lot of treatments out there that increase the risk of causing problems. Other things that we think about: radiation therapy, increasing the risk of heart valve disease, coronary disease, pericardial disease or disease of the heart sac, arrhythmias or heart rhythm problems, autonomic dysfunction, which has to do with fluctuating blood pressures and fluctuating heart rates as a result of radiation therapy. Then there's more recent therapies like CAR T-cell therapy and stem cell therapy, which some people with lymphoma who have aggressive lymphomas end up receiving these therapies. And these also can increase the risk of heart disease or heart problems. And then hormonal therapy, which we usually use for breast cancer and prostate cancer, also increase the risk of heart disease. And so in this, when we are thinking about the population, we know that the most populous cancers, the cancers that we see the most, are prostate cancer in men and breast cancer in women. The ones that cause deaths in the United States, amongst all cancer patients, Hodgkin's lymphoma is up there, counted as top 10 causes of death in the United States, but these are deaths from cancer. Again, when you're talking about death from heart disease, Hodgkin lymphoma is actually top. We would consider it number 1 or number 2 when it comes to death from heart disease. And this particular study shows it nicely when we're thinking about death. According to death from heart disease in Hodgkin lymphoma survivors, and even non-Hodgkin lymphoma survivors, total deaths according to heart disease was up to 12 to 13-fold higher amongst those with Hodgkin lymphoma and about 4.4-fold higher among those without Hodgkin lymphoma. The other one I showed you that was 31-fold was in kids. This one is in all comers, so kids and adults. So it's a major problem. And depending on whether you're talking about age, it doesn't really matter. Younger age group up until middle age, the risks are higher. The risks are still high regardless. The decade of diagnosis, whether they were diagnosed in the 1970s, 1980s, 1990s, in the 2000s, the risks are still pretty significant. And the length of follow-up, in other words, whether you're following them for 5 years up to 30 years plus, the risk is still significant and high. And when we're talking about anthracyclines and how they reduce cardiac function or cause heart failure, you can see here a normal heart cell, well organized. And then when you add chemotherapy or anthracycline, including doxorubicin or adriamycin, this is what you get. You see how disorganized and what we call vacuolated. In other words, fat cells start to build up and you develop fibrosis or scar tissue forming in between those cells. And this is what eventually leads to heart failure. So you can see a normal heart, and then this is a heart that has been affected by doxorubicin. These very distorted and disorganized, and we get what we call a dilated cardiomyopathy. In other words, the left ventricle gets big and is not able to pump blood as well as it should anymore. And these toxicities can be what we call acute, within 1 week of treatment, subacute, usually within 1 year of treatment, chronic, within 2 years of treatment, or long-term. Most people fall within the subacute category. So usually, initially as they're getting treatment, maybe, but usually within the first year, you have most people develop the toxicity, usually about 90 to 95% of people, but you still have those that are at risk for late long-term toxicities that have certain risk factors. And when we think about these risk factors, you have the dose of the anthracycline. So the higher the dose, the more the risk, especially when you start getting above 450 milligrams per meter squared. Luckily, the lymphoma patients receive a lower dose, usually about 300 milligrams per meter squared, at least the first time around. But then some of these patients may end up, if they develop recurrent lymphoma, may need to receive higher doses, or maybe they had breast cancer first and now they have lymphoma, or the other way around, then they may end up needing to receive higher doses of the doxorubicin or anthracycline. So it's a cumulative dose, a lifetime dose, not just a dose at one point in time. And then other factors that we think about, the type of anthracycline, so doxorubicin or what we call adriamycin produces or confers the highest risk for developing heart failure compared to some of the other anthracyclines that we think about. Radiation, especially if it's radiation to the chest, especially if it's radiation to the chest in somebody who has received doxorubicin or anthracyclines, that risk is higher. Other drugs that are given with anthracyclines sometimes If they have pre-existing cardiac risk factors like high blood pressure or heart disease already, those people are at higher risk. Comorbid conditions like kidney problems or lung problems increase the risk. Then age. I talk about something called the Bimolda distribution. So people who are really young or people who are really old are at highest risk. So people who are really young in single digit ages, little kids, those are at higher risk because their hearts are still developing and then they end up receiving this toxic agent at the same time. And then those that are older, age greater than 65, are at higher risk as well because their heart function or heart issues, their heart, the heart being able to tolerate toxicities is very low. So because of that, it's very, very easy for them to fall off the curve if you give them anthracyclines that are cardiotoxic. And women are actually at higher risk compared to men also. So that's something to be aware of. So it can cause different, radiation therapy is another one that I wanted to talk about, which can cause different kinds of heart problems. The kinds of problems that you can get with radiation therapy include atherosclerosis or heart artery blockage, heart block or heart rhythm issues, tight or leaky valves, especially the aortic valve is the one that's affected the most. We're going to hear from Mr. Cunningham after this. Inflammation or fluid around the heart. So you can have the heart sits in a sac and that sac can develop inflammation around it, which can cause fluid to build up around the heart, which can cause its own issues or chest pains. Racing heart or heart palpitations that have to do with autonomic dysfunction. So this is what we see. You have radiation. If you have, let's assume this is a coronary artery, and you have radiation that affects the coronary artery, and you generate this sort of inflammatory process with radiation, which then ends up leading to what we call foam cell collection that build atherosclerosis that builds up within the walls of the heart arteries. This is what increases the risk of blockage of the heart arteries and then increases the risk of heart attack as well. So when we think about radiation-induced heart disease, is dependent on the dose of radiation. So the higher the dose to the chest, the higher the risk of heart disease from radiation. Usually once you get above 30 gray is where we start to get concerned. Or if you get more than 2 gray per day to the chest, that's also another concern. More with left-sided radiation, which kind of makes sense because the heart is on that left side. So we need to be careful about that. If they have baseline heart disease or heart disease risk factors, that also increases the risk. If they've received present or past anthracycline therapy, particularly with adriamycin, that risk is higher. And this risk is, we used to think that the risk only came about 20 years after treatment and then for the rest of the life. But we're finding more and more that even within 5 years of treatment, that risk is still elevated and the risk actually increases with time. So risk of all of these problems with radiation therapy in people that receive chest radiation increases with time as people get older. And so this is what we see. So when you get, this is a dose-dependent damage. So the heart cell is a little bit organized here at 15 gray centigrade that was administered to a mouse. And then you can see here, by the time they got up to 20 centigrade on that mouse, how disorganized and distorted that heart cell is. And so when we think about preventing heart disease in cancer survivors, it says breast cancer survivors, but really this is something that can be applied to most cancer survivors. We have to think about a few things, what we call the ABCDEs, awareness of risks of heart disease, thinking about whether the patient needs to be on aspirin. For those that receive chest radiation, we usually recommend that those patients go on a baby aspirin for the rest of their lives, really. And I've had a bunch of people that have come to my clinic, maybe I've put them on aspirin, and now with all this new press about aspirin, people are asking, oh, should we be on aspirin? And my answer is yes, because you're not the general population that the press is talking about. You're not the general population that was included in those clinical trials. Blood pressure should be controlled aggressively, especially if you've received anthracyclines, because blood pressure, like I showed you in one of those slides, blood pressure is one of the risk factors for heart disease associated with anthracycline therapy. Use of cholesterol, making sure the cholesterol is controlled, quitting tobacco smoking, diet and weight management. Knowing the dose of the chemotherapy and or radiation therapy that you receive, because that's really relevant as you live on as a cancer survivor, to be able to pass on that information and be an advocate for yourself to the physicians that are going to be treating you now or in future. Diabetes prevention and treatments, then exercise, and knowing when you need to get an echocardiogram or an EKG. And when we talk about exercise, this is in patients who have Hodgkin lymphoma, you can see in this study, they took the Hodgkin lymphoma survivors and they put them in the exercise stress lab. And they compared those of the Hodgkin lymphoma survivors that received chest radiation versus those that did not receive chest radiation. And they tried to assess them based on exercise parameters. They found that those that exercised less had higher risk of heart disease, cardiovascular events like stroke, heart attacks, heart failure, and so on, high risk of coronary disease events like heart attacks, higher risk of valve replacement therapy, higher risk of heart failure. So this is really relevant that exercise is very, very good for improving problems with heart disease associated with Hodgkin lymphoma. So this is something that's really important. So what sort of symptoms should we look out for when we're concerned about people with heart disease after they've received cancer treatment? Chest pains, shortness of breath, leg swelling, dizziness, lightheadedness, or fainting spells, palpitations. If anyone has any of these, or you know someone who's a cancer survivor that has any of these, please ask them to see their doctor and bring up to their doctor the fact that they received treatment and should they be concerned about these symptoms. Because in the end, I'll tell you, a lot of cancer survivors survive cancer, they go on into the community and they see their regular doctors. And it's very easy, honestly, for their doctors to forget that they ever received cancer treatment. So if the patient does not bring it up to their doctor to say, hey, I received these sets of treatments, should I be concerned? The doctor may never think about it. And at the very least, even if the doctor doesn't really know, maybe it's a primary care doctor who's out in the community, who's not used to seeing these patients and who's not really aware, at least ask the doctor to refer you as the patient to someone who knows more about this and can do something about it. And so when we're thinking about the cancer patient, in cardio-oncology, we see them prior to treatment and evaluate them, manage them prior to treatment. We see and evaluate or manage them during treatment. And we also see and evaluate and manage these patients after treatment as cancer survivors. During treatment is usually if they develop problems with treatment. Before treatment is usually if there are risk factors that the oncologist have concerns prior to treatment starting. And then afterwards, as cancer survivors, I think I've kind of alluded to the sorts of things that we usually think about. And so I will stop here and I will take any questions any of you might have. I'm happy to answer. So thank you so much.
Thank you very much, Doctor. It was so full of so much information, and I think we definitely have the awareness part covered now. And even though you told us about what we could do for ourselves, I think we need another quick reminder about the diet and exercise. Do you see that in your practice?
What is the question? Do I see diet and
diet and exercise, what we can do for ourselves to help mitigate all of these risk factors?
Yes. So, that's actually one of the things I should have included was a study that we conducted. I led the study within the Women's Health Initiative that basically showed that patients who were exercising prior to diagnosis of cancer had less risk of heart disease after cancer. So after they had cancer, got treated for their cancer, the risk of heart disease and strokes was less, much less actually, in those that were exercising prior to cancer diagnosis compared to those who were not. So yes, the bottom line is I particularly emphasize exercise in my clinic. It's very, very important to me. And anybody who knows me knows this, because I think that of all the, I was once interviewed by someone from the press or whatever, and they asked me, of all the cardiac risk factors and of all the things that we as human beings can do to mitigate the risk of heart disease, which one do I think is the single most important thing? And hands down, without even a thought, I said exercise. If you had to pick of everything, what can you do to mitigate that risk? Exercise. And I can tell you that amongst our patients who are on chemo, I can tell those that are receiving the same sets of chemo, I can tell those that used to exercise prior to cancer diagnosis and those that did not, because you can tell those that used to exercise tolerate chemo so much better, do so much better, end up in a hospital so much less compared to those that never used to exercise before they started chemo. And those that continue to exercise through chemo, and studies have shown this too, actually do better overall in terms of tolerating chemo, and then also later on as cancer survivors. So I can't overemphasize the benefits of exercise, and I do encourage my patients. I always tell my patients, yes, I know if you're getting chemo, you're gonna get tired, there's no doubt about that, but if you can at least try to get 30 minutes, 20 to 30 minutes of exercise in on most days of the week. If you can do every day, that's ideal. But you can break it down, because studies have actually shown, let's say you're exercising for 30 minutes on average, and you do all of the 30 minutes all at once, say walking, whatever, jogging, biking, you do all of the 30 minutes at once, versus if you decided to break it down 10 minutes 3 times a day, 15 minutes twice a day, the benefits that you get are about the same. So you can break it down, right? And I'm not talking about physical activity in the house, like, oh, some patients say, oh, I do chores and I move around, and yes, that's good, but that's not what I'm talking about. I'm talking about getting up, either getting on a treadmill or walking outdoors or walking your dog, or just doing something that increases your heart rate, that makes you, maybe even makes you sweat a little bit. 10 minutes 3 times a day, 15 minutes twice a day, 30 minutes at a time, or if you can do more, then more is fine. 45 minutes an hour, as much as your body tolerates. That's really very, very important. So yes, I see this all the time. And yes, I do talk to my patients, and yes, we see benefits.
Excellent. We did have a question regarding exercise in advanced heart failure patients, and what would be considered doable or safe for that.
Yeah, so actually there have been studies that have looked at advanced heart failure and looked at cardiac rehab. As I'm sure anybody, the Medicare, Medicaid, and a lot of the insurances will cover heart failure and cardiac rehab, because the data and the studies out there are pretty strong for benefits associated with exercise. We give, when people have heart failure, obviously we give a whole bunch of medications and stuff to those patients, but exercise has been shown to reduce the rates of hospitalizations, and also has been shown to reduce the risk of death, and has been shown to improve the quality of life in patients who have heart failure. So we emphasize it. So when people get a diagnosis of heart failure, as soon as they're getting discharged that first time, the next thing is we're sending you to cardiac rehab. Because of the benefits that come with exercise. And the general idea behind cardiac rehab is, at least initially, you're exercising under a monitored setting. So in other words, they're keeping an eye on you, they're monitoring your blood pressures, your heart rate, and maybe even EKGs from time to time as you're doing the exercise. And then usually after about 3 months, then you can go out on your own and you can start doing those same things on your own. But the first 3 months is usually in a monitored setting. And again, it's because of all the benefits that we've seen amongst heart failure patients who exercise. Excellent.
We do have another question regarding many of our survivors have faced open heart surgery versus TAVR. And they're wondering what factors play into that in deciding which one is best for the patient.
That's a very good question. So some of the things that we think about that makes us decide one thing or the other, let's say a Hodgkin lymphoma survivor who got radiation, right? Now, years later, maybe they have coronary artery disease, and maybe they have aortic valve disease, which again is pretty common in this population, and they have coronary artery disease at the same time. In such a situation, we would prefer to do bypass, right? We would prefer to do open heart surgery, because we have to treat the coronary artery, especially if they have extensive coronary artery disease, and at the same time have the aortic valve disease. If they have an aortic valve disease that's complicated in the way it's diseased, right? So maybe they have significant aortic regurgitation, which is the backflow of blood in the heart. And at the same time, they have significant forward flow problem with tightness of that heart valve. Depending on how complicated it is, if the interventional cardiologist that's supposed to be doing the TAVR doesn't feel comfortable with it, in that kind of situation, we would opt to do an open heart as a result. So I think a lot depends on the number of things and on the issues and the number of things that we're dealing with that particular patient. Now, of course, if it was 10 years ago, it would have been open heart. Nowadays, we kind of think about one versus the other, depending on what's going on with the patient. Now, the problem with open heart also, especially in those who have received chest radiation, is that the chest radiation scars the chest. So making open heart very, it can be deadly or higher risk of complications as a result. So it's something that we tend to be really careful about in making that decision, especially again, if they've received chest radiation.
Okay, thank you. Also about we had a couple questions about surveillance testing. And one of them was, how often do you suggest repeating rest echoes versus stress echoes?
Yeah, that's a very good question, and one that it's tough. It's tough to decide. Excuse me. Definitely within as soon as the doxorubicin chemotherapy is done, that person should definitely receive an echo. Definitely. So you get one at baseline and one at the very end. And of course, if there's a concern while the patient is getting treatment, they should definitely get one during treatment. Definitely, the patient should also get one by 1 year after treatment, because again, like I showed you in one of the slides, the risk is highest within that first year. So we always get one within a year. And I think that based on the findings, based on what you see, the recommendation, especially if they've received chest radiation, is to then reevaluate those patients every 3 to 5 years, depending on what's going on with the patient. So that's usually the general rule we tend to follow. For me, in my lab, my cancer survivors, I see them annually. The cancer survivors that I'm worried about their heart, I see them annually. And each time I see them, I will always get these two cardiac markers, the troponin and the BNP, especially the BNP. The troponin is kind of a little bit iffy sometimes, especially in cancer survivors. While they're going through treatment, I get the troponins and the BNP for sure, because those are very useful during treatment. After treatment, I tend to focus more on the BNP. If the BNP is stable, I will just keep following them. And then at 3 to 5 years, I will get another echo, depending on usually their age and a whole bunch of other things that make me decide to get an echo. But if there's an elevation somewhere with the BNP, I always get an echo. So even if it's a year later, 2 years later, whatever, as long as there's an elevation in BNP from what it used to be, that usually tells me there may be something going on, and I'll usually get an echo. But I can tell you for sure that for the patients that I see in my clinic, those that are pretty aggressive about making sure their risk factors are controlled, communicating with their physicians regularly, all of that, those patients tend to do and they're exercising regularly and doing all the right stuff. Those patients tend to do pretty well overall.
Okay. Another thing question was about using a carotid ultrasound to extrapolate the result of that to how the carotid arteries, the arteries around our heart are doing.
So that's a very good question. Using the carotid artery to make that decision is a little bit tough. So yes, the general idea is that if you have a problem, atherosclerosis in one of your arteries in one place, chances are that you have atherosclerosis in an artery in another place. So the main way that we use the carotid artery to make a decision is to use it as a risk marker. So in other words, if I do a carotid ultrasound and I see atherosclerosis, that basically suggests to me that there's disease elsewhere. And so I'll be more aggressive with things like putting you on a statin therapy, putting you on aspirin, counseling you on diet, counseling you on exercise, that kind of thing. So we think about carotid stenosis as a risk marker. Now, of course, if your carotid stenosis is completely blocked off or blocked off significantly, then we have to have a conversation about whether it needs to be fixed. We usually don't fix it unless the patient has symptoms. But if the patient has symptoms, usually having to do with a curtain or cloak-like blinding of the eyes and so on, then we usually would go ahead and fix that carotid artery. But other than that, other than a place or a situation where the patient has symptoms, we usually think about carotid atherosclerosis as a risk marker.
Okay. This is kind of a broad question, but would be very helpful to know about. How do we go about finding a cardiologist that can address our experience with Hodgkin's and our treatments? What are the questions we should be asking?
Yeah. So how do you go about finding a cardiologist? I think that number one would be to search on the internet. Maybe Erin can speak to this and how she was able to find me and other people, I'm assuming. What the sorts of questions to ask would be the things that we discussed, right? So asking questions, first of all, finding out from your oncologist. I think it's important to know what treatment you received, because that's usually when patients come to my clinic, we always try to get records of those patients ahead of time, because it's important for me to know what treatment you received, what doses of those treatments that you received, whether radiation was involved or not. And if radiation was involved, was it radiation to the chest, what treatments you're on currently. those sorts of things. So it's important to, first of all, know empower yourself as a patient by knowing the treatments that you've received or that you are receiving. And then when you go to see the doctor, you can then ask them maybe about side effects or problems that you're having as you're receiving treatment, or problems that you had while you were receiving treatment. Of course, then whatever other issues, let's say you're a cancer survivor, whatever issues that you're having at that particular time that you're concerned about, you should bring them up with your patient. I always advise patients to write down concerns. Whatever concerns you have, write them down, because when you go to see the doctor, because our time is limited, a lot of doctors are usually in a rush to finish the visit and leave so they can get to the next patient, because the hospital is always pushing us to go very quickly. I try not to do that with my patients, but still, every patient should write down the questions so that they know the questions that they're asking the doctor, and they don't go home saying, oh, this, I should have asked this, or I should have asked that. And then that's number one. Or number two, what some of my patients do is that if they think about questions, they just send me a quick MyTrap message. These days of technology, send me a quick MyTrap message. So I have it. And then when they come to clinic, I will just pull up the MyTrap message, and then we can go down the list and answer them. Either way, it's fine. The point is just make sure that you have your questions prepared ahead of time to discuss with the physician.
I just want to jump in there for a second. Yeah, the issue of finding a clinician is a pretty broad one in our group. And I'm looking at one of the questions we had in particular from Amy, who asked about like having had a cardiac history and had radiation at a young age. She was told by her non-cardio-oncologist that she didn't need repeat echocardiogram for another 3 to 5 years. So I guess the question is twofold. One is, you know, if you're getting conflicting directions from your PCP or your oncologist, and you know that you have a heart issue, how do you reconcile those two different suggestions? If you know that this is a concern for you, and they may not be as savvy about cardio-oncology as you want them to be.
Yeah, no, but you already answered the question, Erin. And the thing to do would be to say to your primary care doctor, I'm a little concerned. Could you refer me to an oncocardiologist or cardio-oncologist? That's really it. Because in the end, the primary care doctor, it's not that they don't have their own medical knowledge. They do, but the primary care doctor has to think about so many things. And so you're better off going to, in that situation, you're better off going to a specialist who does this every day for a living, because they would be up to date on the data. They will be up to date on the information out there and on all the research, and they would have better advice for you, because this is what they do, as opposed to a primary care doctor who is basically a jack of all trades, so to speak, who knows a lot about everything, but they may not be up to date on each of those individual components of health.
Sure. Okay. Thank you. What else have we got?
We've got a few more questions. One is on beta blockers that are past the prevention stage. So survivors from Hodgkin's that are past prevention, they already have heart disease. What are your recommendations, generalized of course, for medications that will help our cancer survivors now, or harm? Is there medications that will harm us as well that we should stay away from? There's been a lot of controversy about statins and things like that, and beta blockers. So for heart disease and what we are facing, what is your thought? Yeah,
so no, those are great questions. Beta blockers, actually most of my patients I put on beta blockers for a couple of reasons. If we're talking about lymphoma particularly, with the use of anthracyclines or beta or doxorubicin specifically, beta blockers, studies have shown that carvedilol particularly, I shouldn't say studies, I would say the theoretical assumption is that carvedilol particularly has what we call antioxidant properties. In other words, it has properties that heal the cells as they're being destroyed. And so for that reason, we usually like to put these patients on carvedilol. A good number of cancer survivors as they get older have developed high blood pressure or hypertension. And hypertension is a risk factor for developing heart failure as a result of doxorubicin. So if I had to treat those patients' hypertension, I would usually reach out for a medication that I feel may have some benefit from a heart failure standpoint and heart failure risk associated with doxorubicin. And so I would usually pick carvedilol in that setting. Now, if they already developed heart failure, carvedilol has excellent data for reducing the risk of death associated with heart failure. So I would still have a reason to put them on carvedilol regardless. If they received radiation therapy, one of the risks that come with radiation therapy is the risk of what we call autonomic dysfunction. I kind of mentioned this a couple of times. And autonomic dysfunction basically means situations where, as a result of the inflammation with the radiation that causes some level of scar tissue, we have nerves that run around the neck area and around the chest area that innervates the sympathetic nervous system and also the parasympathetic nervous system. So control the fight or flight response, which then controls things like blood pressures and heart rates and water retention and things like that. So when there's chest radiation and these nerves are damaged, controlling those parameters the body finds it difficult to control those parameters. So people can easily get problems with blood pressures dropping too low very fast or going up very fast, or heart rates going up very fast for no reason or coming down very fast. And so these fluctuating blood pressures are just heart rates that just stay up and they never really come down. Those sorts of, or blood pressures that are low and never really come up, those sorts of issues, those constellation of problems are called autonomic dysfunction. And one of the ways that we treat autonomic dysfunction is to put them on a beta blocker, because a beta blocker would kind of modulate the autonomic nervous system. So it's not kind of going crazy like that. And so that's one of the ways to treat it. So overall, the bottom line I'm trying to say is that there are multiple reasons for me to use beta blockers in a lot of cancer patients and survivors. But again, that's tailored to whatever therapy that they receive. So I do have a lower threshold for starting beta blockers on patients, but that being said, I do always have a good reason for doing it. And I always support whatever decisions I make with data.
Another question is, for testing and things like that, cardiac MRI and echo, can you use them in conjunction with each other, one substitute for the other?
They're not substitutes. I would say that a good way to think about a cardiac MRI is an advanced echo. Let me just put it that way. So an echo is excellent for screening, right? So when we're talking about all the problems that we get with treatment, be it heart failure or valve disease or pericardial disease or pulmonary hypertension or whatever it is, an echo looks at the heart, looks at everything to do with the heart, and it does a good job of it. A cardiac MRI it has what we call better resolution. So the cardiac MRI also looks at the heart like an echo does, but the cardiac MRI gives us better detail to the things that we're seeing more so than the echo. And so we usually can do usually the echo first. And then if we have concerns on the echo, then we usually would go with the cardiac MRI to kind of better decipher those things that we're seeing on echo. That's usually the way we think about them. If somebody ends up deciding, if somebody for whatever reason, it would be very unusual because insurance companies wouldn't really cover just doing an MRI without first doing an echo. But if for any reason somebody gets an MRI first and doesn't do an echo, there are certain things about the flow of blood through the valves and things like that that we also look at echo that may not necessarily look at the cardiac MRI. So usually echo is the way to start, and then there's just sometimes reason to do a cardiac MRI beyond the echo.
Another question, and this is actually my personal question. I had radiation from ears to groin in 1990 and high doses. I've already had breast cancer and I'm getting ready for aortic valve replacement. So I haven't had a heart attack episode, but does that still put me at high risk when you were talking about breast cancer and cardiac episodes? Does that still put me at a higher risk for reoccurrence for the breast cancer, even without the heart attack, or is the heart attack the key to that risk factor?
So that's good. That's a good question, but that's something that we're still trying to answer.
Mm-hmm.
Because like I said, studies are suggesting that people who have a heart attack are at higher risk for having things like developing cancer or having the cancer kind of grow and things like that. But these are all things that we're still thinking about from a research perspective that we don't have as good data for, not yet at least.
Okay. There's another question where a number of survivors have many different issues done with their heart. So if there's an immediate concern and that issue is taken care of, how does it affect the remaining issues? Can they get better? Do they get worse? For example, doing TAVR, but then it affects your mitral valve positively or negatively.
Okay, I think I'm trying to understand the question. A broad way to answer that question is that nothing exists in isolation. So one problem in one part of the body can easily lead to a problem in another part of the body. Doesn't always have to happen, but oftentimes different parts of the body are connected. So if you have a problem in one part, it can cause a problem in the other part. I recently had a patient who also was a lymphoma survivor who ended up receiving chemo and radiation therapy, mediastinal radiation years and years ago. And then more recently, she had problems with her mitral valve and her aortic valve. The mitral valve problem was not really bad. We decided to go ahead and do TAVR for that aortic valve. And then after the TAVR for the aortic valve, the mitral valve problem seemed to be more significant. It doesn't mean the TAVR caused the problem. It's just that the TAVR created some hemodynamic shifts that made the mitral valve problem a little bit more relevant later on. And so she ended up having to go for what we call a MitraClip procedure. But in the end, this is something that she was aware of that could be an issue before she went into the procedure. So again, like I said, different parts of the body are related in different ways. So it's important as a physician it's important as a physician to have a broad lens when we're looking at issues related to the body, rather than just having a telescopic lens where you're just looking at one thing and not thinking about everything else.
I just wanted to jump in there. Excuse me. Again, sort of a personal question, but there are several of us who are dealing with tricuspid issues, and there don't seem to be as many good solutions for repair of the tricuspid valve or replacement as there are. Could you speak more about that and what may be coming in the future? Why is that the tricuspid has been not as, it's kind of forgotten.
It's a forgotten valve, right? So,
yeah.
So one reason is that the left side of the heart, as cardiologists, left side of the heart ends up being more important than the right side of the heart. To a certain, I'm not going to say that the right side isn't important. It's extremely important. I will have to say that. And I think as cardiologists, it's something that we didn't recognize as much years and years ago. The focus was usually always on the left side of the heart. The mitral valve and the aortic valve being the two valves on the left side of the heart. Those two valves are more exposed to higher pressures. So the way it works is that blood comes from the right side, comes from the rest of the body into the right side of the heart, makes its way through the tricuspid valve, the pulmonic valve, and into the lungs. When the blood gets into the lungs, it gets oxygen, right? And then the oxygenated blood, the good blood, or the rich, nutrient-rich blood, then goes to the left side, to the mitral valve and the aortic valve, and then flows out to the rest of the body. The blood flowing out to the rest of the body, so all the pressures on the left side of the heart are under higher pressure because they're pumping through to a whole bunch of organs on that left side of the body. So the pressure is higher. Because the pressure is higher on that side, the aortic valve and the mitral valve are more liable to having problems as people get older. Overall, compared to the right side that usually is a lower pressure system. So a lot of the developments in technology and the rest of them have particularly focused on that left side. And then also because all those valves on the left side are pumping to the rest of the body, they seem to be more immediate in terms of their problems, because if there's a problem pumping blood to the rest of the body, then the rest of the body is going to suffer. So it's more noticeable when there's a problem on the left side. But the problem on the right side, because you still have the lungs in between, and then the left side is already there to compensate for issues for the right side. The right side it's a little bit easier to compensate for and less noticeable as a problem. Unfortunately, less noticeable as a problem until it gets too late. And then it becomes difficult to do anything about it. And then by then it's kind of like the patient's already not doing well, and then it's difficult. So right-sided valves we tend to ignore, but we really shouldn't. Because once the patient has developed a right-sided heart failure, it becomes really difficult to take them to surgery because the mortality is pretty high at that point. So we're kind of learning in cardiology to notice tricuspid valvular problems before the patient develops significant right-sided heart failure so that we can do something about it. In terms of technology, there are some minimally invasive valves that are coming. There's none that I know of for the pulmonic valve on the right side, but for the tricuspid valve, there are minimally invasive options. Right now, what we have using clinically right now are temporizing measures that are not really serious. They may kind of tie the patient over for a year or two or something like that. But there are trials in development for sturdier options for that tricuspid valve that are minimally invasive that can be managed accordingly. Now, for now, if you wanted to do, if anybody wanted to do anything that's valuable or that's long-term, that's durable long-term for somebody who has tricuspid valve disease, it would be an open heart surgery. And yeah, for open heart tricuspid valve disease, that where there's no significant right-sided heart failure, there are options now that we can do what we call a tricuspid annuloplasty, and more uncommonly a tricuspid valve replacements that can be done with open heart. Hopefully that answers your questions, Erin. I know it was kind of complicated.
We're gonna I think Kathy and Gail let you go, and if you can stay, that's great. We wanted to get to David's presentation, but we had a full hour full of fantastic questions, and I know there's probably a million more, but I think we could keep you all day and listen to what you have to say. And I want to thank you for what you're doing for us. You not only have you done this today, but you're helping us with our website, and it's been terrific. I wish we had a million more people like you out there. I think it's just important to say that you know, what we've learned from you is tough. This is tough news for people who are listening today. And I think not everybody was aware of how important these cardiac issues are. Some of us were, some of us are not. So it's really helpful to have someone explain it in a very thorough and caring way. We need more of that. So thank you.
Thank you so much. And thank you, everyone. It's been a pleasure, Erin. Thanks for inviting me. I'll stay for a couple of minutes just so I can see Mr. Cunningham present, okay, and then I'll head out. Thank you so much, everyone.
Okay, take care. Thank you.